Today's topic is plasma cell disorders. So in the previous one, we discussed the lymphoid disorders, and now the last topic of the lymphoid disorders, the plasma. We talk about the B cell development because plasma cells is developing from the B cells. This development is starting in the bone marrow when we do have a progenitor lymphoid cells that is going to have this somatic mutation, recombinant mutation, or is called this VDJ recombination. First, this VDJ recombination is going to influence the heavy chain, and after the light chain. And when we do have this recombination, the pre-beta cells is getting out from the bone marrow and is getting into the circulation and reaching the lymphatic node. And in the lymphatic node, that be an antigen is presented to these cells, and it's not suffering, but it's happening, a hypermutation, a somatic hypermutation that's going to produce a polyclonal immunoglobulin secretion of the cells, and this is how the plasmablast is going to develop. And first, the IgM lymphoplasmacyte is produced, and after we do have in the lymphatic node, we do have this switch recombination when it's shifting the class, and the plasma cells that's secreting IgG, IgA, or IgE is getting back toward the bone marrow as well. Now, when we do have these disorders that it cells, first of all, in an early stage, when this pre-beta cells is affected or suffering a multi-step mutation, this is how the acute lymphoid leukemia is going to develop. Now, when you get out and when you do have this almost mature B cells or beta cells, that's the origin of the chronic lymphocytic leukemias. And in the lymphatic system, in the lymphatic node, usually the Burkitt lymphomas or the follicular lymphomas, and when we do have the IgM altered or clonally altered cells, that's going to form the Waldenström macroglobulinemias, or when we do have this bone marrow affected IgG, IgA, or IgE secreting cells, those be the multiple myeloma. So these are the different diseases that can affect the B cells or the lymphocytes or the plasma cells. Now, the plasma cell disorders, as you see here, it's going to take about 15% of the all malignant cases of the that is affecting the white blood cells, and 1% of the all cancer that could be due to these plasma cell disorders. A plasma cell disorders is characterized by a secretion of the monoclonal immunoglobulins. This is what is called the paraprotein, or when we do have the serum electrophoresis, we do have a very narrow peak in a gamma fraction that is called M protein. So the presence of the M protein is going to mark a plasma cell disorder. If you look at the classification of the plasma cell disorder, the majority or the less severe condition that is called monoclonal gammopathy of undetermined significance, or MGUS. This takes about 62% of the all cases. And usually from this stage, we do have the following one, such as the malignant monoclonal gammopathies is in the multiple myeloma. They do have a variant is again in severity, such as the smoldering myeloma or non-secretory multiple myeloma or light chain myeloma or plasmacytoma or solitary plasmacytoma of the bone or extramedullary plasmacytoma, and more severe ones such as the plasma cell leukemia when the plasma cell invades to the peripheral blood as well, or when we do have the lymphatic node involved, the bone marrow involved, Waldenström macroglobulinemia, such as the name for this is a lymphoplasmacytic lymphomas. And we can have another problem when only the heavy chain is synthesized. For example, the heavy chain of the IgM or IgA or IgG, for example, is synthesized, or the immunoglobulin deposition diseases such as the amyloidosis, primary amyloidosis, or systemic light chain or heavy chain deposition diseases. We are not going to talk about the all diseases. We are going to mention only few, such as the MGUS, and multiple myeloma and plasmacytoma and so on, but we are not going to talk about the others. Let's continue with the different. Now, let's see how can we investigate when we are going to suspect or monoclonal gammopathy. First of all, we are going to do this complete blood count, especially for checking red blood cells, platelet, or white blood cells. Because when we do have an abnormal clonality in the bone marrow, usually the normal cells are suppressed. Another thing, serum protein, calcium, and immunoglobulin composition should be checked as well, because the serum protein usually increases tremendously. If somebody does have elevated protein level, mostly this is due to a proteinemia. The protein level can be as high as 100, 120 grams per liter. And the calcium usually is enlarged because the plasma cell activates osteoclast and causes a resorption of the bone. And for sure, the immunoglobulin picture is going to change, and monoclonality can be seen on the serum for electrophoresis. You should check the serum and protein and urine electrophoresis that's showing this M protein, or immune fixation when we are using an antibody against this kind of immunoglobulin that is produced, and this is very sensitive to detect any changes. Another thing, again, the bone lytic processes can be checked by X-ray of the skeletal bones, or bone marrow evaluation for checking the amount of plasma cells in the bone marrow could be checked, or not for diagnosis but as prognostic sign, beta-2 microglobulin could be checked, because beta-2 microglobulin is going to be synthesized by these inflammatory cells, and because it's a teeny tiny amount of protein that is going to be excreted into the urine. Now, if you are measuring in the serum the elevation of the beta-2 microglobulin, meaning that we do have an increased production of the beta-2 microglobulin, plus we do have a problem with the GFR, because if you cannot excrete into the urine, that causes an accumulation. If you are measuring in the urine, you can measure as a tubular function marker, because small molecular weight protein is going to be reuptaken by the tubular cells as well. So this beta-2 microglobulin is a good substance to measure the kidney function, or here they are using as a marker or the prognostic sign for multiple myeloma. Now, this is how the serum protein electrophoresis looks like when we do have a gel, and we are going to apply these plasma samples and run in electrophoretic field and separating the different, as we learned, albumin, alpha-1, alpha-2, beta, and gamma globulins. Now, this is how normally looks like. In immunoglobulin, the IgG, IgM, and IgA usually is found in the gamma fraction, but in some areas, some of them is going to extend into the beta region as well. Now, when we do have this monoclonal pattern, as you see here, in the gamma band, we do have a very narrow, large amount of protein, and that we call as an M protein. So this is how we call it as a monoclonality, because the same kind of protein, the same molecular weight, this is why it's a very narrow of this section. The immune fixation is more sensitive than a serum protein electrophoresis, and immune fixation is performed only when they do have a peak of this gamma fraction, and after with immune fixation we should confirm that the presence of the M protein, plus we can determine what type of immunoglobulin, IgM or IgG or IgA or IgD, what kind of immunoglobulin we do have, and especially we can identify whether the light chain and what type of light chain we do have. Now, if these two processes relatively measures or diagnosing the same kind of thing, why do we use both? Because immune fixation is very sensitive, however, it does not give you any kind of clue about the amount of this M protein. As serum electrophoresis is going to tell you, or somehow is correlated with the amount of protein, why immune fixation is sensitive, but it's not proportional to the amount of protein that we do have. This is why, as a prognostic features of the treatment, we should know how much M protein we do have in this. Now, not only plasma cell disorder can cause a narrow M peak or M protein accumulation, but transiently, for example, viral infection can cause this. Transient means doesn't last longer than 1 or 2 weeks, and after the M band is going to go back to the normal area. Or chronic infection or lymphoproliferative diseases such as a CLL, again that can cause a little M band. Or autoimmune disorders and other autoimmune neurological conditions such as a Guillain-Barré syndrome. Certain endocrine disorders, liver disease, especially the autoimmune hepatitis or hepatitis C viral infection can cause, and certain tumors, for example, such as the breast carcinoma, can cause a transient M protein presence in the blood. So not only the plasma cell disorder, such as a multiple myeloma, is going to cause this M protein elevation. Now, when we should suspect that the patient could have some paraproteinemia? First of all, if the patient presenting pancytopenia, anemia, thrombocytopenia, agranulocytosis, you should check the cause of it. Can be radiation, can be chemical, but can be, for example, due to leukemias or any other hematopoietic system altered neoplasia. Pathological fracture, because these plasma cells lives in the bone marrow and causes an accumulation or activation of the osteoclast. This is why the bone is going to weaken, causes local osteoporosis that can cause pathological fracture in this patient. Pain, bone pain, because these plasma islets or plasma cell accumulation happening in multiple areas. Basically, when you weaken the bone, the stretching the bone is very, very painful because nerves ending on the surface of the bone all the time that can be felt. Renal failure, especially when we do have light chain accumulation and tubular necrosis can happen in the, or amyloidosis can develop in the kidney, that can cause renal failure. Or when somebody diagnoses plasmacytoid lymphoma, for example, IgM accumulation, and hyperviscosity, for example, Raynaud phenomenon, when the acral area is cyanotic or cold finger, especially when you go out with a colder area, that could be due to hyperviscosity that caused by an accumulation of the IgM molecules. So these are the conditions when you have to test, for example, for this paraproteinemia. And I should give an additional one, in some case, autoimmune disorders. If you do have some rashes, papules, or vasculitis that you cannot explain, you are going to check the serum electrophoresis because, for example, the hepatitis C viral infection or monocular gammopathies or MGUS can be behind of this situation, the immunologic diseases as well. Now let's start with the mildest form and the most common one, that is called the monoclonal gammopathy of uncertain significance, or this is usually called as a benign monoclonal gammopathy. Benign because there is no clinical sign at all. Only a laboratory sign we do have. We do have a stable, low concentration of the M protein in the serum. That is what the patient has. Nothing else. The patient does not have M proteins in the urine, so there is no protein excretion in the urine. We do have not reached, let's see, 10% or higher plasma cell number in the bone marrow, so the bone marrow is not infiltrated by plasma cells. We do not have any kind of bone lesion or hypercalcemia or anemia or renal insufficiency. Not at all. Only we do have, relatively, we do have a narrow, a low amount of M protein in the plasma. That's it. And there is no other B cell proliferation, so we cannot state that this is some kind of proliferative disease at all. Only you do have a monoclonality. That's it. Now, why is it so important? Is it important because the incidence is increased by age. If you're looking at an adult one is 40 to 70, it's about 1%. Relatively, it's very rare. However, over 70, between 70 and 80, about 3%. Over 80, about 11%. And over 90, 14% is the amount or the number of the people who are suffering of this MGUS. And why is another importance of it? Because this can progress to the other monoclonal diseases, more severe diseases, such as, for example, multiple myeloma, amyloidosis, or other related plasma cell disorder, especially if the patient did have an IgG or IgA MGUS. If they do have an IgM MGUS, it can be progressed to non-Hodgkin lymphomas or CLL or Waldenström macroglobulinemia easily in the future, later on. Now, this MGUS, so we assume that is MGUS a prediction for the progression. So basically, if somebody does have more M protein, they have a higher chance that is going to be progressed. Or if the patient does have IgM or IgA monoclonal band for MGUS, they have a higher risk to progress into, let's say, other more advanced condition. Or if you do have IgG, relatively the chance is less to progress. This progression risk is relatively constant. It's usually about 1% per year, it meaning about 10% in 10 years or 20% in 20 years. This is how they are going to progress. Now, what the patient, how you should handle the patient, you have to monitor closely the patient. Every year, you should monitor the patient with a serum protein electrophoresis, looking for the M protein, and this should be done for the whole life as the patient lives. So you want to discover as early as you could the progression of these diseases. Now, the multiple myeloma is the next step. This is when we do have clinical signs and symptoms as well. Again, inside this multiple myeloma or its variation is going to differ in different cases. So the mildest one that is called is an MGUS. So this MGUS relatively is an asymptomatic precursor for multiple myeloma. Now, as multiple MGUS relatively, the next step from MGUS is a smoldering multiple myeloma, SMM. That's relatively, we don't have as much plasma cells in the bone marrow, but we do have M protein as well. It's already started to develop. Multiple myeloma, when we do have M protein, we do have plasma cells in the bone marrow, we do have the all clinical sign that could develop with bone lesion, with kidney problem, with hyperviscosity, so the all symptoms that can develop in multiple myeloma. And in more severe condition, this process can enter into relatively the final one, the plasmacytic leukemia, when the plasma cells is going to invade into the bloodstream as well. Not only the organs are filtrated with plasma cells, but into the blood we do have these plasma cells. Normally there is no plasma cells in the blood. You do have in a connective tissue, you do have in a bone marrow, you do have in the lymphatic system, but nothing in the bloodstream. Now, how do we think that this process is going to transfer? We do have a normal plasma cell that is going to be transferred and somehow is a stable intermedullary expansion inside the lymphatic node, and we are going to produce a little bit more monoclonal protein, so immunoglobulin protein. But we do have only a few cells. But these few cells, not only one or two, but they do have enough protein that could be detected. Next one, we do suffer of another mutation that is going to induce the proliferation or decrease, let's see, the apoptotic signal of these cells. And now this is going to progress to the intramedullary expansion, and we do have the all clinical sign. we do have suppression of the erythroid cell line. We do have a suppression of the thrombocytic cell line or the granuloid cell line. And it activates the osteoclast and causes bone lesion. So this is when the lytic bone diseases or anemias or organomegaly develops. And that's usually when you do have the all clinical symptoms that due to multiple myeloma. There's only one problem with this multiple myeloma is incurable and the survival rate is very, very limited. In the United States, we do have about 13,000 deaths per year due to this multiple myeloma in every, about 1% of the all hematopoietic neoplasia, the death caused by this plasmacytoma. Based on this table, you can see here the different type of diseases, and this is the progression rate that starting with MGUS, smoldering myeloma, solitary plasmacytoma, multiple myeloma, and plasma cell leukemia. As you see here, every disease contains this M protein. We do have this monoclonality. However, in MGUS, we don't have more plasma cells in the bone marrow. However, in others, one smoldering, solitary, multiple, we do have. But the clinical symptoms is going to develop when we do have the solitary plasmacytoma or multiple myeloma or plasma cell leukemia. And only in plasma cell leukemia, we do have plasma cells in the peripheral blood. There's a very rare form, very special rare form that is called non-secretory myeloma, when we relatively has almost no monoclonality or very teeny tiny amount of M protein we have. However, we do have plasma cell invasion, multiple invasion in the bone marrow. This again relatively is going to progress into the plasma cell leukemia very easily in a very high number. This is why it's listed here. Now, the smoldering myeloma, we do have an increased M protein. However, we have no clinical sign. We don't have any kind of organ manifestation. So there is no bone lesion, there is no anemia, there is no bone marrow involvement. So we have not enough plasma cells in this bone marrow. Doesn't require any kind of therapy or intervention. Only survival chance is a close survivance is necessary to ensure that the stability of the diseases, such as serum protein electrophoresis, blood cell count, serum creatinine checking their kidney function, calcium for the bone effect, every 3 to 4 months. And X-ray for skeletal survey to see immediately any kind of bone alteration or fracture or maybe a lightening or osteoporosis that you can start treating the patient in advance. The next one, this is a very rare, as you see here, it's about 1% of the all cases. This is a non-secretory myeloma. This is with bone lesion or not, but no serum or urine monoclonal protein can be diagnosed. Renal failure and hypercalcemia are generally lacking because there is no immunoglobulin or light chain. Anemia may be present because we do have plasma cell accumulation in the bone marrow. And depending on the severity of this condition, from 20 to 75%, the bone marrow is infiltrated with plasma cells. And monoclonal protein bound can be diagnosed from the bone marrow smear. So in the bone marrow smear, you can diagnose this clonal origin plasma cells that is going to synthesize a very low amount of immunoglobulin that is not going to invade to the plasma. Solitary plasmacytoma usually is a localized plasma cell tumor that is only one area of the body, is not a multiple location. So maybe in some area of the bone or in the subcutaneous, usually in the bone or the lymphatic system is affected. There is no cell infiltration from random biopsy. However, there is, of course, is no evidence of bone lesion because only one area is affected yet. Usually we have no renal failure or hypercalcemia or anemia, but 50 to 60% of these cases is going to progress into the multiple myeloma within 10 years. So this is why it's getting very close to the more severe disease. Extramedullary plasmacytoma can develop, for example, subcutaneously, especially in the neck areas, that the patient does not have any other features of the multiple myeloma. Again, there is no skin, there is no bone marrow infiltration, so no anemia, no thrombocytopenia, no bone marrow disorders or bone lesions, and no renal failure is going to develop. Only you do have, for example, subcutaneously an accumulation of these plasma cells. If you are going to remove, for example, by resection, relatively is cured and you don't need to do anything with it. If you cannot remove the all, radiation is another, let's say, step of the therapy, but the patient usually is cured. It's about 1/4 basically has some monoclonal spike. Now the next one, that's a more severe condition, and that's the multiple myeloma, when we do have the typical sign, the all clinical signs of multiple myeloma in this patient. This is an uncontrolled proliferation of the Ig secreted plasma cells, most commonly IgG, about 57%. IgA is less common one, and when we do have only the light chain, is close to 20%. Now, why this light chain is important? This light chain is filtrated by the glomeruli, is getting into the tubular system, and can cause tubular damage, amyloidosis, so the kidney. This is why it's important one. In any kind of hematopoietic system, the disease or neoplastic disease usually has a male dominance compared it to the other diseases, but these are the important aspect as well. And this multiple myeloma takes about 15% of the all hemopoietic tumors. As you see in every year, for example, about maximum of 9 cases per 100,000 population. So in Hungary, for example, counting about 10 million with the population, about almost, well, 1,000 disease can be diagnosed in every year. And one problem with the survival rate, the 5-year survival rate is around 35%, so it's relatively very low. Multiple myeloma, to diagnose multiple myeloma, as we already started, I think Now, let's see what is going to cause the manifestation of this clonality of the plasmacytomas or plasma cell proliferation. When we do have an effect of this plasma cells that altering the osteoclastic activity increases and osteoblastic decreases, this is how the bone lesion is going to develop. Plus, we do have the hypercalcemia as a consequence of the increased osteoclastic activation. If you do have an IgG deposition, light chain, heavy chain, or any kind of hemoglobin in the kidney, that can cause kidney failure or renal failure. And due to the mass effect in the bone marrow that suppress the erythropoiesis or the thrombopoiesis, that's going to cause anemia, relatively very severe anemia, and thrombocytopenia. And due to the monoclonality, that the normal cell number decreases, this is why we do have a decreased gamma globulin or globulin levels. So this is why the patient has an immune paresis, so a very common infection that can develop in this patient who has this monoclonal gammopathies. When you're looking at the lab test, the first thing that you should ring the bell, the ESR, the erythrocyte sedimentation rate. This patient has a relatively very high ESR, over 100. Normally, if you do have an infection that usually over 100 or 150, we do have an acute bacterial or fungal infection. Below that value can be viral infection or autoimmune reaction or anything of the C-reactive protein, for example, or ESR. Now, this patient who has this over 100, very high chance that this patient does have this globulin fraction increased. This is why it's sticking together the red blood cells and the sedimentation rate is increased tremendously. Renal insufficiency, anemia or thrombocytopenia can be present as well. Renal insufficiency, hyperproteinemias, proteinurias, especially the light chain, about 20% of the cases. That's the Benz-Jones protein that can be detected by serum protein electrophoresis or immune fixation. It's not going to detect, for example, with a dipstick in the urine. So by using a urine dipstick evaluation, this Benz-Jones protein cannot be detected. However, if you use the physicochemical features of this Benz-Jones protein, you can start heating the urine. And when you heat it up about 60 centigrade, we do have a precipitation of this protein. And if you continue heating it at 80 centigrade, it's going to dissolve back. So it's going to clean up. Where you do have an albumin, for example, another protein in the urine, it is not going to dissolve if you start boiling the urine. That's a good differentiation, but they are not using it, so they are using the immune fixation of the urine electrophoresis as well. Hypercalcemia, beta-2 microglobulin, LDH, very important. LDH is very, very important because if we do have a disease when the cell turnover increased, or we do have a damage of the cell system, the LDH activity is high. CRP only showing that if we do have infection, for example, repeated infection in this case, and these are the prognostic features, so they have prognostic significance to check. Now, this is how we can explain how and why the bone is involved in multiple myeloma. A long time ago, they could not figure out what could be the cause why the plasma cells usually sitting in a little nest in the bone marrow. And they can cause a punctured bone lesion, for example, in the flat bones. After they figure out that this kind of multiple myeloma cells, these plasma cells, is going to secrete some ligand that can activate, for example, the rank cycle and activates the differentiation or the function of the osteoclasts. So one, we do have a system that is going to activate or going to increase the proliferation of this protein. In return, this osteoclast gives an anti-apoptotic factors to the plasma cells. So, in neighboring, these two cells lives happily to each other. One can get some proliferation, and other can get some, let's see, anti-apoptotic signals, so the accumulation. So this is why when the plasma cell comes and meet with an osteoclast, they start to communicate each other, and they start to proliferate. In the plasma cells, you do see the proliferation of plasma cells in one area, and osteoclast proliferates in the same area. The X-rays show, let's see, a hole or the lysis of the bone in a local area, and the bone marrow smear causing an accumulation of the plasma cells in the same area. And because we do have an osteoclastic activation, this is why hypercalcemia and pathological fracture can happen. But not only the osteoclast is going to be activated by this ligand, but we do have a plasma cell origin osteoblast inhibitory factor that is going to inhibit the bone formation. This is why bone lesion and osteoporosis can be the sign of this multiple. Now, if you're looking at the peripheral smear, you can see this called Rouleau phenomenon, when we do have a sticked red blood cells. And if you do have a plasma cell leukemia, you can see plasma cells in the peripheral blood, normally there. However, in the bone marrow, we do have an accumulation of plasma cells. And as I said, in nest in an area. The normal amount of plasma cells in a bone marrow is less than 10%. When we do have a multiple myeloma, it's more than, let's say, 10% or 30% of the cells is already plasma cell. This is how, for example, the flat bone skull looks like. You do have a puncturing of the bone. Looking at the X-ray, you can see the weakening of the bone. This is why the density is going to increase, because the X-ray is penetrating easier through this bone. And that's the punctured lytic lesion in the skull in multiple myeloma. Pathological fracture, for example, the vertebrae or in other areas, the flat bone area can be affected as well. Now, the staging. The staging is very important, basically, to choose the treatment or to see the prediction or the survival rate. Now, the stage 1, relatively, that's the mildest form of multiple myeloma. The microglobulin level is less than 3.5, and the serum albumin concentration is in the normal range. Now, the survival rate is around 62 months, meaning that it's about, how much is that one? It's about 5 years. About 5 years or a little bit more than 5 years. In stage 2, a lot of books says that neither stage 1 or stage 3, but it meaning that the beta-2 microglobulin level is between 3.5 and 5, or we do have a low level of beta-2 microglobulin, but the albumin already decreased. In stage 3, then the survival rate around 29 months, that means about more than 2 years, it's almost 2.3 years. And we do have increase, very much increase of the beta-2 microglobulin, so that's relatively the closest to the end. Therapy, what they use, they're using a tumor growth inhibition, so they are going to control the growth of the plasma cells with a chemotherapy agent. And they can use autologous cell transplantation, but only in younger patients, usually is younger than 75, and the cardiovascular status or the O status of the patient should be good, because when you are going to kill the O cells in the bone marrow, and if you want to replace it, that's a very high risk, for example, to suffer of infection or some other problem, and the patient can die very easily. So this is the problem. And the supportive therapy should be given, such as, for example, inhibiting the osteoclastic activity using this biphosphonate, or irradiation, or curing the fracture surgically. Nephropathy should be treated with hydration or dialysis. Plasmapheresis is good for hyperviscosity, hypercalcemia, anemia, erythropoietin transfusion, or to prevent the infections, you should insulate the patient or use antibiotic therapy as earlier. Now, we do have this case, however, you do have another case for the final one. This is only an explanatory case, how a patient looks like when they do have a bad myeloma. This guy is a 65-year-old with hypertension and osteoporosis. He suffered of intensive vertebral and costal pain that required a combination of NSAID and tramadol therapy over the past few years. In the past 4 months, X-ray and bone scintigraphy confirmed multiple costal fracture and vertebral compression fractures needed vertebroplastic surgery. This surgery, how they use some kind of plate to restore the normal bone structure. Despite maintaining a good appetite, he lost about 10 kilograms in the last 4 months. He is bedridden because of the pain and weakness, no other complaints or symptoms. Okay. They did a smear. Low cell number in the bone marrow, approximately 30%, mostly mature plasma cells are present with eccentric nucleoli and with small nucleus surrounded by plasmaphilic cytoplasm. More than 50% of the bone marrow were plasma cell, as histological slides showed it. Interstitial infiltration is present, and the normal ratio of other hemopoietic cells could be obtained. Immunohistochemistry showed that the presence of the CD138, that's a plasma cell marker, okay, monoclonal plasma cell marker, and the cytogenetic did not show any kind of cytogenic abnormality, such as a P53 or 1q21 or the translocation of 4 to 14. So these are the bad prognostic factors. So these patients who suffered of multiple myeloma, the chemotherapy, that is a combination of chemotherapy they're applying and bisphosphonates to inhibit the osteoclast activity, or pain management to decrease the pain. Waldenström macroglobulinemia, a B-cell lymphoma, and this lymphoid cell is going to produce IgM. Now the incidence comparing to the others is less. With all cases of multiple myeloma, only 10% of multiple myeloma, again, male dominance, and the median age around 63 years. So that's a later aged population affected. Now the clinical presentation is less severe than multiple myeloma, and less renal damage, less hypercalcemia, and no lytic bone lesion can be detected. Hyperviscosity, however, is a leading sign, or bleeding as well, or neurovisual disturbance due to the hyperviscosity or Raynaud phenomenon. Hepatomegalosplenomegaly, a lymphadenopathy can be diagnosed as well. And when we make the diagnosis, IgM paraprotein is increased. This is why it's Waldenström, because it's a huge IgM secreting plasma cell we do have. And if you do a histological evaluation, you do see this lymphoplasmacytoid cells. Therapy, chemotherapy or plasmapheresis to control the hyperviscosity. And relatively, the survival rate is better than in multiple myeloma if the hyperviscosity is very. Other type, in consequence, plasma cell leukemia, when we do have about 2 gigapeliter of circulating plasma cell, the leukocyte count usually is exceed the 10 gigapeliter, and or it over 20% is plasma cell. Very extensive bone marrow infiltration, and the therapy resistance form of these diseases. Light chain deposition, when we do have the predominantly kappa, but light chain immunoglobulin could be diagnosed as well. And immunofluorescence relatively does not show any the monoclonality of the plasma cells. M protein with incomplete heavy chain lacking of the light chain, or the primary systemic amyloidosis, and other group when we do have this amyloid-related systemic syndrome, positive amyloid staging in any tissues, clear evidence that amyloid is light chain related, established a direct subtyping of the amyloid deposits, and evidence for monoclonal plasma cell proliferation disorder that can happen. So these are the different stages. Well, you only have to know the name. You don't need to know more about this kind of situation.